So, Dr. Larry Wolk. I had one more question. Are you a Seahawks fan? Oh, no, just kidding.
At the
No, you don't have
risk,
to answer. You don't have to answer.
my Seahawks shirt's in my suitcase.
Okay. I know for the Broncos fans, it's still too soon, so I'm sorry. Well, I'm Dr. Larry Wolk. I'm the Executive Director and Chief Medical Officer for the Colorado Department of Public Health and Environment. And CMO used to stand for Chief Medical Officer, and now I feel like it stands for Chief Marijuana Officer. So with that as an introduction, I'm told I have 15 minutes to tell you everything about marijuana in Colorado from my perspective. I grew up back east, so I'm going to recall from a long time ago my back east talk really fast. So if it's too fast, somebody wave their hand at me and say, slow down, will you? Just to give some perspective and how we got here and sort of level set for everybody, I'm going to start with medical marijuana and then move to recreational or legalized. But the medical marijuana program actually goes all the way back to 2000, so 13, 14 years almost now. The registry was established in July of 2001. And CDPHE was never really sort of designated as the entity to kind of oversee this and run this. It was sort of, I think, by default. But we had one FTE, and you'll see in a minute there really weren't a lot of medical marijuana users here in the state for a long time until something called the Ogden Memorandum, which was basically the Fed saying, you know, we're not really going to sort of step in on this. We're going to let you kind of go forth and really do what you want with this program. And so that then led to some additional legislation that then opened the door for the commercial production and distribution to really take off in 2010. And then finally Amendment 64 in November of 2012 on the legalization piece, which, like I said, I'll come back to as well. So this is a graph of the medical marijuana registry with regard to the number of active patients. And as you can see, as I said, for many years we had less than 5,000 registrants or so until 2010 or so, and then things really took off to a peak of 120,000 in the state, and now sort of leveling off at about 110,000. Two-thirds are male, and the average age is 41. So right around my age. So no laughing. No. This is interesting because the question we get asked a lot, and I'm not going to answer it right now, we'll save it as a teaser for questions, is with the legalization having happened January 1st, wouldn't you expect to see those numbers really kind of drop off dramatically? And like I said, I'm not going to answer that right now. So these are the 8 conditions for which medical marijuana is allowed to be recommended. And what I'd point out to you here is look at the top. Severe pain, 103,825, 94%. And for those of you who are analysts or can't read the bottom, this does not add up to 100% because sometimes people have a couple of different conditions. But the overwhelming majority of folks who are getting and utilizing medical marijuana are doing so for pain. And I'll come back specifically to the seizures question here in a minute. And this is my segue to that, which is if you are a sensationalist, you would look at this because this is the number of patients under 18 years old who are in the registry, and you would say since August of this year, there's been a 400% increase in the number of patients under 18 years of age who are in the registry. However, if you look at the actual numbers, that means we went from 50 patients now to about 200. So, let's go back here for a second. 103,000 adults primarily for severe pain as compared to just about 200 only as far as children go, and the overwhelming majority of those are for seizures. So we're not seeing sort of this influx of by the hundreds or thousands or tens of thousands of families moving to Colorado. I think there's some high-profile cases of these kids, and I'd just like to set the record straight that, this is, again, let's keep it all in perspective with regard to who the medical marijuana program really is serving. So this is the slide that could take me down a rabbit hole that could use all 15 of my minutes, or 12 that I have left. I'm going to save some of this and just sort of give you some food for thought, because these are continuing issues, not dissimilar to what Washington is grappling with, yet again, we've had this medical marijuana program going on for years. The first issue is, how many patients can we have per caregiver? And again, for the novices here, you can have a caregiver rather than a dispensary provide your marijuana and your medical marijuana. And a caregiver really is only supposed to have 5 patients at most, and it has to be somebody that you're taking care of, and there's a definition for what a caregiver should be, along with themselves. So really no more than 6 total patients per caregiver is what's written. There's no enforcement really around this to date. We're trying to get some legislation to pass to kind of help tighten that up, because if you're going to take care of more than 6 patients, why shouldn't you be subject to the same regulation that a dispensary or a business center has? But this has become a way. We have more than 5,000 registered caregivers in the state. So a significant number of caregivers in the state, most of whom are abiding by the guidance that says it's 5 + 1. But we have a number of caregivers that are taking care of dozens, if not over 100 patients without much enforcement. And so this is a continuing issue. The number of plants per patient, I asked a bit of a loaded question, because the Constitution dictates that there's a standard amount, and the standard amount is 6 plants or 2 ounces, and it's a possession amount, so it's not a restriction based on time or anything else. But the Constitution also says that with medical necessity, a physician can recommend, and then you're entitled to even more, something that's considered an excess amount. And so I was curious about this. I had just started this job in September, the first day of the floods. So I was a little preoccupied in September, but by October I got around to looking at marijuana. And so I spent a weekend looking at the number of excess amount requests just for the month of October alone. And there were more than 3,000. So we get a fair number of requests where physicians are recommending excess amounts, and not based on a whole lot of medical necessity. The number one reason in that little spot for medical necessity that's given is edibles. It just says edibles. So there's no real community standard that's being followed. When a physician is making the recommendation, they're basically making the recommendation because they're being told, oh, I need to recommend 99 plants or 33 ounces, which is not an uncommon excess request, just because of edibles. So we've got some challenges there. There's, to my mind, not enough of a following of a standard of care when it comes to the physician documentation, the physician follow-up for many of these patients, providing what we would consider in the medical profession as objective information. Are you checking vital signs? Are you seeing the patient back every couple weeks or every couple months? Are you looking at different doses? There's really none of that occurring. So we're trying to sort of take a look at that and really make sure that it conforms to what we would consider a community standard. And a shout out from me to the industry folks, because a number of industry folks really want this. They really want to make sure that if we're going to have a responsible medical marijuana industry in this state, that we are going to conform to true community standard when it comes to recommendations by physicians. Adding new medical conditions, and then, of course, treatment of children are ongoing issues. So all of that leads to kind of an exciting opportunity for us here in Colorado, which is that we're one of the few states that can actually now conduct research because of the legalized status of marijuana. So we have a bill that we hope will get introduced sometime within the next couple of weeks that will allow us the spending authority, because we already have the money as a result of money that was charged as medical marijuana registration card fees, so that we can take now actually almost $10 million and oversee a research program that I say is going to be reality-based. we don't want to sort of get into these long sort of clinical trials where we have to procure our marijuana through a single federal grow site in Mississippi that doesn't represent the reality of our situation here in Colorado. We want to take the products that our residents and our citizens are using, we want to put those through lab testing, and we want to see people come together to say, hey, we really want to study the safety and efficacy of these products, and we want to embark on observational studies, and yes, maybe even some clinical trials, so we can start really demonstrating what the true efficacy and the true safety of medical marijuana is. And then we're also going to use some of this data to say, hey, are there conditions on this list that maybe shouldn't be on this list anymore? And are there new conditions that we should be considering to add to the list? So that's my segue now to the retail marijuana or recreational marijuana. I'm not really going to go through this all that much other than to say that this time around, we do have some specified roles for Colorado Department of Public Health and Environment. We have a section that specifies that we'll monitor changes in drug use patterns broken down by county, race, ethnicity, and the emerging science and medical information relevant to the health effects associated with marijuana use. And that we'll have a panel of healthcare professionals with expertise in cannabinoid physiology to monitor the relevant information, and that we're going to have a report from this panel by January of 2015 and every 2 years thereafter. And that panel is going to have the appropriate expertise in order to make recommendations as appropriate for policies that will protect consumers of marijuana or marijuana products and the general public. So, I know there's a lot of you here in public health, and, it kind of makes your head explode sometimes to think about all of the different places that bringing in something new that was previously illegal, that's now legal, that we know a fair amount about, touches so many different aspects of public health. And so from our perspective and from the legal perspective and the regulatory perspective, we, one, have to monitor the health effects that we heard quite a bit about this morning, with an eye on contaminated products, accidents and injuries, poisonings, chronic health issues. Our role in education and prevention, both us and our local public health agency partners when it comes to adult abuse, adolescent use. You heard about pregnancy and nursing mothers, product safety and storage, and harm reduction. Infused product safety, which I'll talk about in a second. Laboratory practices. There is no FDA when it comes to, certifying, the edibles or these products. So we have to sort of create our own mini FDA here in the state, which means that we have to have labs, we have to do lab testing, we have to have appropriate labeling, and we are just getting started on that, and we're following the lead of some other states that have some advice and have some track record when it comes to this. And lastly, the one that nobody ever seems to talk about or think of too is the waste disposal. I mean, a lot of these products only use a certain part of the plant, or they only use a certain process, and there's a fair amount of hemp waste and marijuana waste that's created. And so we have to have some sort of process and procedure around what we do with that waste. So in the interest of time, this represents pretty much all of you here in the room, so thank you for collaborating with us. Okay, I can't even see this, but this is meant to demonstrate that, and a shout out to Dr. Tista Ghosh, who is the Deputy Chief Medical Officer, who's sort of where are you, Tista? I know you're here. Wave your hand. There she is back there. That's our sort of marijuana leader. And she's really put a lot of time and effort and thought into this. And it's really great because the whole department has come together to say, we're going to have this recreational marijuana steering committee that works with this external committee that was created that I talked about by the legislation. And we're going to bring in each of our departments in each of these areas, whether it's the data itself, whether it's the Indoor Air Act. You all know that the Clean Air Act actually doesn't just apply to tobacco, but it also applies to plant products, smoked plant products. So I've been saying thank goodness for clove cigarettes, because I think when this was written, it was meant to capture the clove cigarette smoke, and luckily it also captures the marijuana smoke too. So it does impact our environmental health divisions, like I said, food safety, our lab division. So a very busy slide to tell you that we have a lot of busy people. But we have so much legislation and so much crossover between medical and recreational and all this, we really feel like that at least within CDPHE, we're going to have this kind of overarching marijuana advisory panel that will have external folks as well as internal folks, myself included, and each of these entities are going to kind of roll up to it, whether it's the recreation program, whether it's the registry, or whether it's these research studies that I've talked about, and having oversight into determining how those get structured and how those get conducted. We have a lot of different data sources that we'd like to sort of revise so that we can capture data. We're already out there collecting data through Healthy Kids Survey, the Behavioral Risk Factors Survey, Tobacco Attitudes and Behavior Survey, and the PRAMS, which is the Pregnancy Risk Assessment Monitoring System. So I think relatively easy and relatively inexpensively, we could take some existing data sources and surveys and beef them up so that we can answer a lot of these questions that people have. We also have death certificates, hospitalization records, emergency department visits, EMS response, the problem identification report that CDOT provides, the all-payer claims database, the birth defects registry. But I think we'd like to sort of learn even more and maybe start doing some marijuana-specific syndromic surveillance and even look at making this a true reportable condition, because that's very much specific and in line with our state. And we have an example of this, and again, shout out to Tista and her team. We had a pretty significant synthetic marijuana outbreak a few months back, shortly after I started, and we learned a lot from that. I mean, that's synthetic marijuana in this case, but there were over 200 emergency room visits amongst young people, most of whom were attending a concert that had access to this synthetic product. And the thing that we learned, as you've heard over and over again, is, you know, marijuana can mean a lot of different things and can contain a lot of different substances, bacteria, mold, chemicals, pesticides, lead, formaldehyde. I mean, you know, one study showed there were like 30 different substances contained in one particular product. So we want to use that so that we can actually take a look at how we're going to ensure food safety or substance safety or plant safety, whatever you want to call it, and we have a good real-life epidemiologic study that we can follow. So specific to education and prevention, you've heard the list already. We at CDPHE are going to develop the statewide website portal, which will link all of the other state agency portals. So whether it's CDOT or whether it's Human Services, we want people to sort of feel like there's at least one place they can come to get this information. And we're also doing it on behalf of the governor, who feels very strongly about the public health messages and about making sure that kids are adequately informed and we're doing everything we can as it relates to kids. And not to slight anybody, but a shout out to Denver if Denver's here. I think Denver has their site up and running. So congratulations for being kind of the first out of the gate. Maybe during questions we can find out if other local public health agencies have gotten their sites up yet as well. So we have a number of different supplemental budget requests where you've all sort of seen the amount of tax revenue that's going to be generated or that's already being generated. And it's going to be a little bit of a cash grab, I think, like the tobacco piece, because I think everybody's kind of got their sort of project that they'd like to see funded. So we have our list, and I've already hit those, and I see Chris is standing up, which means I'm getting a high sign. So we do have a couple of resources already on our site, so please feel free to go to it. Mike Van Dyke and Ron Hyman, your names are up in lights there. People can contact you for information, and I was feeling guilty, so I added my name too. Please feel free to give me a call, and thank you very much.
So Mary or Summer, do you have any questions?
Well, I have that question that you gave me, Chris, so I'll do that one. Just that we've been kind of working with some folks at the state as local public health in terms of, we know that some of the educational materials and that sort of thing that we might be able to build upon, but are there some other specific ways that we should be looking for collaboration?
I mean, this is, again, sort of uncharted territory for us. And what we want to do is be talking to each other and make sure that we're giving consistent messages. Not that we want to control that. We started with taking federally available information so that we could be ready on January 1st. To your point, in Washington, it's hard to get ready and start spending money on something when you don't have the money to spend. So we are going to include local public health. I whipped through that in each of those committees, but we want to make sure that we at least have consistent messaging amongst all the different state departments, but also between the state and the local public health agencies.
Mary?
I'm not a Broncos fan. I'm sorry.
I'll leave that one alone. I want to say kudos to your website and the information that's out there. I think you've done an excellent job. But speaking a little bit to one of the things that came up this morning, a question that keeps coming to us is with alcohol, especially teenagers and college students in particular, focusing on harm reduction. And there is no really good research on harm reduction related to marijuana. Have you talked about a way to address that? I mean, we can talk about driving and waiting and some of those things, but in terms of levels of use.
We have, and again, we're lucky because we have actually at the governor's cabinet level, we've got a marijuana committee that includes Department of Transportation, Department of Revenue, Department of Public Safety, as well as us. And so it's actually very high on the priority list, but we don't have the practical how-to just yet.
Okay, we'll struggle through that together.
Yeah.
Thank you.
One final suggestion. I think if you are thinking about changing the idea for youth, you might want to change the name from recreational to adult use or legalized use.
Yeah, that's my own sort of slip because, I think we started by saying recreational, and I keep trying to say legalized, but I'm with you.
Thank you.
Yep.